Thank you very much for the kind introduction. Thanks to the Foundation for Rehabilitation for allowing me to be here and to be back finally in China after a few years. I would like to make a little journey together with you about the meaning and the importance of the peri-implant soft tissue collar, and try to understand why we need to perform soft tissue boosting or management. I publish quite a lot on the management of the peri-implant mucosa, so we learn a lot of different tips and tricks over the last 25 years of experience. So first of all, when we think about the peri-implant mucosa, we have to focus on a specific tissue, which is completely different compared to the gum, compared to the gingiva. We have multiple collagen fibers running parallel to the implant abutment and a very relatively thick connective tissue. When we look into the details of the peri-implant mucosa, we see that we have an adhesion between the mucosa and the titanium abutment. It really doesn't matter if we are dealing with a zirconia abutment or titanium abutment, we still have an adhesion. A very fragile adhesion, but it's there through hemidesmosomes. When we talk about peri-implant mucosa, we need to distinguish three different areas of interest. The connective tissue, that goes from 0.7 to 2.6 millimeter, which is rich in blood vessels and is the closest one to the implant platform. Then we have the junction epithelium, which does not present blood vessels, and it ranges from 1.4 to 2.9 millimeter. Both of these two different types of tissues are in contact and adherent to the implant abutment. And finally, we have the sulcus, that goes from 0.2 to 0.5 millimeters. So we have a lot in the literature about this type of soft tissue collar. What it makes the difference mainly compared to the gingiva is that the collagen fibers run parallel and not perpendicular to the long axis of the implant itself. The blood supply in the teeth comes from the periosteum and from the periodontal ligament. In dental implants, we have the blood supply coming only from the periosteum and eventually the endosteum, but we don't have, of course, the periodontal ligament. The biologic width of the implant, it's about 3 millimeters versus the average of 2 millimeters of biologic width of the natural dentition. Both attachment, the gingiva and the mucosa, are based on hemidesmosomes, mainly concentrated at the junction between the connective tissue and the long junctional epithelium. But why we need to focus our attention, why we need to spend time in the clinics to boost the peri-implant mucosa? Well, the most important aspect of the peri-implant mucosa is to create a sealing and protect our implant. We know that internal connection, a CC connection, is the best to allow to get this type of sealing, but it's also true that the faster is the sealing that we can get with the peri-implant mucosa, the less chances we have to get bacterial contamination. So the most important role is the sealing. Every time that this sealing is disrupted, then we have all these failures. All these cases, which is something I have to retreat, very common in my practice, I have to retreat all of these cases that have been referred from other colleagues, have something common, which is the poor management of the peri-implant mucosa. Once I have this sealing, which is disrupted, then I have bacterial contamination and eventually peri-implant bone loss and peri-implantitis. Peri-implantitis still is a bacterial type of disease. And that's why the sealing is so crucial to avoid the contamination of the implant surface. Once we have the implant surface which is exposed to the oral cavity, it really tends to accumulate plaque and not that much can be done. So we need to focus the attention on the peri-implant mucosa to prevent peri-implantitis. When we start looking at the numbers, they are quite scary. The incidence of mucositis goes from 40 to 48%. About half of the implants that have been placed are characterized by mucositis. And the incidence of peri-implantitis goes from 10% of the implant to 20% of the patient. These are really scary numbers. The majority of the implants that we are looking today are failing or ailing. Failing means that an implant is exfoliating, it's mobile, needs to be removed. An ailing dental implant is an implant which is not perfect, is still a survival implant, but is not perfect in terms of aesthetics and in terms of health of the implant itself. Maybe implant with exposed threads, maybe implant with the mucositis or peri-implantitis. These are ailing dental implants that still need to be treated. If we focus and if we develop technique to boost the peri-implant mucosa and to obtain this sealing very rapidly, then we will have less chances to deal with the ailing dental implants. Then, of course, complications can occur. Complications are part of medicine, are part of dentistry. And there are consequences also of a therapy. In that situation, we would talk about a iatrogenic dentistry. But also there are consequences of a disease or also health condition. So I would like to summarize 5 different points for which the peri-implant mucosa is so important. First, we already talked about that, the sealing. The peri-implant mucosa is important to prevent bacterial ingrowth and the apical migration of the biofilm, which is responsible for mucositis first and then peri-implantitis. There is a lot already reported in the literature about the prevention of bacterial migrations. And the soft tissue sealing is the only parameter that we can play with in order to avoid the migration of the biofilm. One important concept is to avoid as much as possible the subsequent reconnection of the abutment. Every time that we remove an abutment, we are disrupting this delicate and fragile adhesion between the connective tissue, the junction epithelium, and the abutment. So we would like to have something so that we have a sort of tissue-level implant or some kind of component, such as the own one, where the working prosthetic components are bring into the sulcus area in order to avoid the disruption of this fragile attachment. Here we have a scanning electron microscope pictures showing that every time we remove an abutment, we have epithelial cells completely disrupted. Once we remove it and we connect the abutment, of course, there is an apical shift of the biologic width and there is an apical shift of the soft tissue sealing. Then, very, very practical type of presentation. Is there any difference in terms of bone tissue response if we use different type of abutment materials? Is there any difference between a titanium abutment or a zirconia abutment? The answer is no. There is no different in terms of inflammatory response. So they are both good type of material that can be utilized. We have a different type of behavior, though, in terms of cells migration. Every time that we're dealing with the fibroblast, they are attracted by rough surfaces. Epithelial cells, whereas, are attracted by super smooth surfaces. And that's why we need to look at very smooth surfaces in the transmucosal components in order to allow the epithelial cells to migrate very rapidly. What about innovation? There have been brought into the market a lot of different tools, a lot of different materials, a lot of different technologies. But an innovation is not only something new. It's something that can give us an extra tool to treat better our patient and to reduce the risk of complication and maybe also to improve our quality of life in daily practice. So we have some kind of components that have been brought into the market a few years ago, which refer to the concept of mucous integration. We know today that based on material characteristics and based also on surface topography and implant connection, we can obtain the perfect attachment between the mucosa and the abutment. Two developments have been the own one, which is bringing the working prosthetic components into the sulcus level so that we don't have to disconnect this component anymore. An exiled surface, which is an anodized type of surface, which tends to have great advantages in terms of speed of migration of the keratinocytes. Of course, the keratinocytes tends to move faster on exiled surface, which means that we can get the sealing very, very rapidly compared to a polished titanium abutment. An extra result that we have with this surface is that we have less plaque accumulation, but also a lower level of bleeding, and we have something we would like to see all the time. We have a higher band of keratinized mucosa every time that we use the exiled surface. So overall, we have a better soft tissue outcomes. And of course, this is already reported in the literature, showing how the speed of migration of the keratinocytes is definitely superior compared to titanium abutment, which were already performing well. So this is an innovation because it's something new, but it's also something that's giving me an extra tool to obtain keratinized tissue. And of course, we see also in this graph that the level of keratinized mucosa is higher compared to the titanium abutment. So now we can choose. We can choose XIL, we can choose titanium, we can choose zirconia abutment. The answer is in the literature. Another innovation has been the TiUltra surface, which is characterized by the rougher anodized surface in the most typical part of the implant, and this surface becomes a little bit smoother the more we approach the implant platform. So in case of complication, which means, for example, perimplantitis, it seems that this implant can be better treated and maintained over time with a smooth collar compared to the complete rough surface. So overall, the exiled abutment is characterized by the fact that, of course, I'm obtaining a better clinical results, but at the same time, I still can have a good cleanability of the sites. Two different types of surfaces for two different types of relationship with different type of tissues, the exiled surface for the soft tissues and the TiUltra for the hard tissue. Still, the wettability is maintained, the hydrophilicity is maintained. I would like to have a very higher hydrophilicity in the most typical part of the implant, and then having a smooth surface and the level of the implant platform to reduce the risk of bacterial contamination in case of exposure. Then, of course, in terms of TiUltra, we have some advantages. For example, we have a higher level of thrombogenicity, which means that we have a better behavior of the cells in contact with the TiUltra surface compared to the previous surface. Also, there is a higher numbers of OH groups, which means that the interaction between this surface and cells is definitely superior compared to other implant surfaces. And finally, of course, still it is absolutely evident the wettability and the hydrophilicity of the implant surface, and also the oxide layer is definitely thicker every time that we use the TiUltra surface compared to other surfaces. The thicker is the oxide layer, the higher is the type of interaction with the host cells. So, in a certain way, we are also stimulating the mesenchymal stem cells to proliferate in contact with this new surface. And the advantage is given by the fact that through the anodization effect, we can really tailor the behavior of the implant. So, go back to the importance of the mucosa. The reason number 2 for which we should have a good quality of the implant mucosa is to prevent peri-implant bone loss. Why? We have an evidence in the literature that is showing that every time that we are dealing with the thin tissue, which means less than 2 millimeters, so the magic number to be remembered is 2 millimeters, we have 6 times higher chances to get peri-implant bone loss up to 1.2 millimeter after 1 year from the delivery of the final restoration. Whereas if we are dealing with a thick phenotype, which means more than 2 millimeters, the average bone loss goes up to 0.21 millimeters. So it looks also that the thickness of the peri-implant mucosa is more important than platform switching components. If we have a plasma switching components, but we're dealing with a thin mucosa, that plasma switching is not going to prevent pre-implant bone loss. So the quality of the pre-implant mucosa is more important than the implant components. Then, is there any difference in terms of bone level and implant abutment materials? Is there any difference between zirconia, titanium, or gold alloy? The answer is no. There is no difference. They all behave quite well in contact with the mucosa. So there's been now a lot of evidence in the literature supporting the fact that if we're dealing with a thin pre-implant mucosa, we can get up to 1.45 millimeters of bone loss, which is not peri-implantitis, it's excessive bone remodeling after 1 year. And this is really a lot, because nowadays we don't think about having the natural bone remodeling up to the first thread of the implant, because that's something which was absolutely common with external X-implant. Nowadays, with the CC connection, we can rely on the amount of bone that we have around the neck of the implant, and certainly we need to pay more attention at the soft tissue in order to avoid this kind of excessive bone remodeling. So overall, whenever we are a thin mucosa, we have, of course, more bleeding, more bone resorption, more recession, we have more lingual plaque accumulation, more apical shift of the tissue, which means ailing dental implants. So an implant which are still functioning, but of course implants which are not healthy. Every time that we have an excessive peri-implant bone remodeling, of course this could be like a prelude then to peri-implantitis, because once the implant surface is exposed to the oral cavity, it can get, of course, bacterial contamination. Then it becomes much more complicated, the treatment of this type of disease. This is an example. For example, a patient came to me because the dentist, at the time of the delivery of the final restoration, was not able to provide a nice aesthetic result. So the patient was complaining about the gray color of the implant, but the issue here is related to the fact that the soft tissue was not managed properly. Another example here is this peri-implant bone loss, is this peri-implantitis. Most likely this is a secondary peri-implantitis after an excessive bone remodeling due to a misplacement of the implant, due to, of course, patient compliance, due to a poor quality of the peri-implant mucosa. So we need to make a big difference between ailing and failing a dental implant. The reason number 3 for which we should have a good quality of the peri-implant mucosa and quantity of the peri-implant mucosa is to prevent higher plaque and bleeding scores. And that's what is important, the level of the keratinized mucosa. So all this information have nothing to deal with the survival rate. We don't care about the survival rate. We care about long-lasting aesthetic and healthy results. Okay, so every time that we have more than 2 millimeters of band of keratinized mucosa, and then of course the sealed surface can be of great help to obtain this type of results, of course we have lower level of plaque accumulation and lower level of bleeding index, which means less level of inflammation. The reason number 4 is during implant maintenance, during the recall program, because if we think that about 51% of the patient who receive dental implants are not compliant, this is another scary statistical results that we see in the literature. But there is now a good news which is related to the band of keratinized mucosa. So in erratic maintenance patients, so about 51% of our patients, okay, if we have more than 2 millimeters of keratinized mucosa, these implants are less likely to experience higher bleeding and plaque scores, which means less likely to show excessive inflammatory response. Reason number 5, finally, is to improve pink aesthetics. But it's the 5th reason for which I need to boost the pre-implant mucosa. And of course, we know that if we're dealing with a thin phenotype, I can see the gray color of the implant through the tissue, which is not aesthetic oriented. If we are dealing with a thick phenotype, of course the biomimetic and the final aesthetic results is definitely more acceptable.